Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hello, Dr. Mingle.
Good morning, Kyle. Good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
We have a great set of questions today, and please remember that you can always send us your questions on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. Okay, let's get started. Our first question today comes from Greg. And Greg asks, there are too few measures for my specialty, so how can I make a MIPS submission that doesn't earn big negative adjustments?
A great question, Greg, and a common problem. 6 submitted measures typically defines a complete MIPS submission in the quality performance category. But CMS understands that not all specialties can find a full complement of 6 applicable measures. There's still some holes in the system, but there are at least 4 net mechanisms built into the rules that can help you. First, look at specialty measure sets. For 2022, there are 47 specialty measure sets into which sort 196 measures. The number of measures that sort into each specialty ranges between 2 and 62. 42 specialty measure sets contain 6 or more measures. 5 specialty measure sets contain fewer than 6 measures. These specialty measure sets are guides. You don't have to prove specialty certification to use any of the specialty measure sets. You should be guided by the scope of your practice. If you use a specialty measure set, you don't need to go outside that set to choose your measures. If there are fewer than 6 measures in the set, if you submit all of the measures in the set, your measure set is deemed to be complete, and the denominator for your score is reduced, eliminating any penalty for a short number of measures. Second, look at EMA. EMA stands for Eligible Measure Applicability. In EMA for 2022, there are 42 measures that sort into 12 clinical topics. Each group of measures mapping to a topic is considered an EMA cluster. If you submit all of the measures in an EMA cluster, and only the measures in an EMA cluster, your measure set is deemed to be complete, and the denominator for your full score is reduced. You can find the EMA clusters defined in a document in the qpp.cms.gov website. Third, look at QCDRs. QCDR stands for Qualified Clinical Data Registry. Don't mistake this for a qualified registry. Apologies, Medicare, I think, tends to use the term registry a little overmuch. But Medicare's intent is to use the QCDR structure to encourage specialty-specific organizations to build and deploy measures specific to their specialties, and not have to go through the full measure acceptance mechanisms that are required to bring measures into the public menu of MIPS measures. There are still measure validation requirements, but there's an expedited acceptance and a limited deployment. Your specialty may have QCDR measures suitable for you. Fourth, if all else fails, apply in advance of the submission deadline for an EUC. Or apply after the submission deadline for a targeted review. EUC stands for Extreme and Uncontrollable Circumstances. In this case, the uncontrollable circumstance is the lack of applicable measures. Now, I've not seen CMS reduce the measure requirement in response to an EOC, but if they accept your rationale, they can eliminate the quality measure requirement, distributing the quality points to the remaining applicable performance categories. A targeted review is intended to be used after the preliminary results for the year's measurements are announced and to ask for an adjustment to the scores. In this application, you document the reasons that more measures did not apply. CMS may or may not agree with your assessment. If they agree, they will grant denominator reduction and calculate a full potential score on a smaller number of measures. Let's review the weaknesses. First, for the QCDR. You're never required to consider QCDR. It's a little outside the MIPS mainstream. QCDRs are typically specialty specific. Each QCDR deals with a small subset of the entire MIPS eligible provider population, and with much of health tech being volume driven, they often have limited capabilities to get data. If your requirements fit their capabilities and you like their measures, and the measures are applicable, it can be a great choice. Second, the weaknesses of targeted review. The weakness of targeted review is that it is after the submission deadline. You're already at risk of a low score when you ask for a review, and you risk being refused. Third, weaknesses of EMA and specialty measure sets. They share the same downside that even though some of the measures in the set might be applicable to you, you still may not be compatible with all of them or with enough to earn a full score. Measure compatibility with your practice has two factors: eligibility and applicability. Eligibility is easily measured. Every measure has specifications that determine which CPT codes and ICD codes in a billing data set make a patient or a visit eligible to be included in a measure. When the number of eligible instances equals 0, you can't use that measure. It's easy to prove, it's indisputable. You just don't have enough eligible instances. A vendor like Mingle Health can help you evaluate your whole billing data set and document the proof that you need of the lack of measure eligibility to support your EUC or your targeted review application. If you're using an EMA or specialty measure set, you identify those measures with a zero numerator and a zero denominator. Mingle Health or your registry vendor does that for you. It's harder when you have eligibility but not applicability. That means you have patients and or visits with the ICD and CPT codes that apply to that measure, but the care the measure represents is not part of the scope of your practice. This happens a lot. There's no hard data to support it. You can lay out your perception of the case in an EUC or a targeted review application, but the decision by Medicare will be more subjective than it is in the case of eligibility. In summary, MIPS success in the face of inadequate measure availability can be as difficult to document as measure success. You may need professional help like that available at Mingle Health. Thanks. Great question.
Thank you, Greg. And our final question today comes from Mary. And Mary asks, is 2022 the last year for a positive adjustment? And if so, why?
Great question, Mary. Positive adjustments don't end. What ends is the exceptional performance bonus. Now, while it has been the case that most of the available positive adjustments have come from the exceptional performance bonus in these last few years, the system is designed to deliver a positive adjustment even in the absence of that exceptional performance bonus. MIPS was designed to use both a carrot and a stick to encourage our healthcare system to provide higher quality care at a lower price. It is designed also as a revenue neutral program, funding the positive adjustments from the negative adjustments. MIPS uses targeted and standardized measurements of quality and cost to create a presumptive comparison of practices on value. Those practices who compare at a lower value suffer the stick of a negative payment adjustment, and those who compare at a higher value enjoy the carrot of a positive payment adjustment. The system is intended, as I said, to be revenue neutral, and the breakpoint between positive and negative adjustments is called the performance threshold, and it's set at the expected average of national value scores. Only money that is retained by CMS on the negative adjustment side is available to distribute on the positive adjustment side. There are three important exceptions in play on those principles. Since the onset of MIPS in 2017, Medicare has been gradually easing in the full power of the program. This has led to a reduction in the absolute loss in any year, which also, since the program's revenue neutral, reduces the potential gain. Now, COVID exceptions have been in place for the last 4 years, during which significant parts of the market have neither been measured nor payment adjusted. Even though scoring has been getting tougher and potential losses higher, the market has been relatively blind to it. There have not been many losses to drive much gain. For the first 6 years of the program, Medicare kicked in a $500 million exceptional performance bonus that is divided amongst those practices measuring well above the average on value. The bonus phased in at a level above the program average, and a higher share of that bonus has been given to those with higher relative scores. Most of the positive adjustment we have been enjoying in the early years of MIPS has come from this temporary extra kick in from CMS. 2022 is the last performance year to which the exceptional performance bonus is available. Positive adjustments earned for 2021 and 22 performance years will continue to pay out through the 2023 and 2024 payment years. Then it's over for good. Now, the ramp up to MIPS has continued relatively invisibly behind the COVID automatic exceptions over the last few years. With the COVID automatic EUC ending, EUC, as I've said in other questions, means extreme and uncontrollable circumstances. Expect scoring to suddenly feel more stringent. With more and bigger losses on the negative adjustment side, there will be more dollars to distribute in the positive adjustment side. Expect low scores to be lower, high scores to be higher in coming years. Thanks, Mary, for a great question.
Yeah, thank you, Mary, and thank you also to Greg for the other great question today. Please remember you can always leave your questions for Dr. Mingle in a comment on LinkedIn or YouTube, as I said earlier, and you can send us an email at hello@minglehealth.com. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks for all the great questions. I want to be helpful and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.